Good day, everyone. Welcome to Anxiety, Depression, and Dementia. Appreciate you all being here today. My name is Arlene Schiff. I am a nurse. I'm an education specialist with Elderwerks. Been in the healthcare field my entire career, working with seniors and their families and guiding them through the journey of aging for over 20. Today's topic is incredibly important because mood and anxiety conditions are highly prevalent in older adults and are frequently underdiagnosed. And this becomes even more complex when dementia is present. Over the next hour, we're going to untangle these overlapping conditions, explore how they influence each other, and most importantly, discuss practical ways you can support individuals in your care settings with evidence-based and person-centered care. So let's begin by reviewing what we will cover today. So our objectives today are we will define anxiety and depression as well as dementia and their relevance to older adults. We will distinguish between anxiety and panic attacks. We'll identify how these conditions impact cognition and dementia progression. We'll recognize symptoms across disorders in older adults, and we'll apply evidence-based person-centered care strategies for persons living with dementia. So before diving into anxiety and depression, it's important to really ground ourselves in what dementia actually is. The DSM-5 replaced the term dementia with a neurocognitive disorder and known as NCD. This includes both mild and major categories. Mild NCD means there's a measurable decline, but people can still function independently, though they may need more effort and strategies or support. And major NCD represents more advanced decline that interferes with daily independence. The definition of dementia has been updated in the DSM-5 criteria, and again is known in that as major or minor neurocognitive disorder. But due to the common use of the term dementia in society and medical literature, we'll be referring to it as dementia in this webinar. So the definition, dementia is not a specific disease. It's a descriptive term for a collection of symptoms that can be caused by a number of disorders that affect the brain. People with dementia have significantly impaired cognitive functioning that interferes with daily activities as well as relationships. They lose their ability to solve problems and maintain emotional control. They may experience personality changes and behavioral problems like agitation, delusions, and hallucinations. While memory loss is a common symptom of dementia, memory loss by itself does not mean that a person has dementia. Doctors will diagnose dementia only if 2 or more brain functions, such as memory and language skills, are significantly impaired. Dementia is an overall term for a particular group of symptoms. So think of dementia as a broad umbrella term that covers a group of symptoms. And the characteristic symptoms of dementia are loss of memory, judgment, language, complex motor skills, problem solving, and other intellectual functions like thinking skills, and they're caused by the permanent damage or death of the brain's nerve cells, or known as neurons. Dementia is a decline in mental function and thinking and remembering and reasoning. And again, to be called dementia, the disorder must be severe enough to interfere with your daily life. Dementia is chronic, it's progressive, there is no known cure. While we know that Alzheimer's disease is the most common form of dementia, there are several other types. The second most common form is vascular dementia, which is caused by decreased blood flow to the brain. Other types of dementia include Lewy body dementia, as well as frontotemporal dementia. And in addition, there are certain medical conditions that can cause serious memory problems that resemble dementia. The specific type of dementia and its symptoms depend on which areas of the brain are affected. For example, Alzheimer's disease primarily impacts memory. Vascular dementia may result from damage to blood vessels in the brain. And it's very important to understand that dementia, again, is not a normal part of the aging process. And some dementia symptoms can be attributed to treatable conditions, making early diagnosis and intervention essential. So when we talk about Alzheimer's, it accounts for about 60 to 80% of all cases. And most individuals also have the brain changes of one or more other causes of dementia. And then that's called a mixed pathology. And if recognized during life, it's called mixed dementia. Difficulty remembering recent conversations, names, or events, even apathy, depression, they're often seen as early symptoms. Communication problems, confusion, poor judgment, behavioral changes, they may come next. And then it's followed by difficult walking, speaking, as well as swallowing are all very common in the late stages. And then 5 to 10% will show evidence of vascular dementia alone, but it is more common as a mixed pathology, with most people living with dementia showing the brain changes of cerebrovascular disease as well as Alzheimer's disease. For this, slowed thoughts or impaired ability to make decisions, plan, organize, these may be the initial symptoms that you would see, but memory may also be affected. Some symptoms of dementia that are caused by treatable conditions are UTIs, urinary tract infections, sleep apnea, depression, which we'll talk about, vitamin B12 deficiency, because a lack of that vitamin can lead to memory problems as well as other cognitive issues. So dementia disrupts how people interpret the world. A busy environment may feel very overwhelming. A new caregiver may feel threatening. A change in routine can trigger fear or confusion. Can you imagine waking up and not recognizing your surroundings? Anxiety then becomes a natural response. And likewise, depression may occur because the person recognizes that they are struggling or because they're aware of their losses. So understanding these reactions as part of the disease, this fosters empathy and guides appropriate care. So again, we take a look at all of these different types of effects that it has on our emotions and behaviors, with the reduced coping skills, sensitivity to stress, difficulty in understanding and interpreting the environment, communication is an issue, changes in sleep, appetite, motivation. There's a loss of ability to self-regulate emotions. So what is anxiety? Anxiety it's a natural human response that becomes problematic when it's persistent, when it's excessive, or it's out of proportion to the situation. People may feel fearful or tense even without a clear reason. So anxiety produces both emotional and physical symptoms in older adults. And in older adults, it often presents differently than in younger individuals. So understanding how anxiety manifests itself helps guide appropriate support. And remember, anxiety isn't necessarily a bad thing. It is an expected part of human behavior. It helps us to remain alert to potential threats. It can motivate us to prepare for an example, an important exam or an important presentation. And sometimes it helps us sort out a problem and make a decision. But anxiety is the most common symptom seen in adults. And again, all of us has experienced it at one time or another. But it's when it becomes persistent and it overshadows everything else that we do on a daily basis, that's when it becomes a problem. So think of it as, that anxiety is the mind's alarm system. So when it goes off at the wrong times or too intensely, it becomes distressing. And in older adults, anxiety can appear subtle, fewer words, more hesitation, or possibly increased physical complaints. So we really have to pay attention to smaller things as well as the larger. So, what is normal versus clinical anxiety? Normal anxiety helps us survive. Clinical anxiety disrupts functioning. People may avoid leaving the house, refuse to go to appointments, or experience uncontrollable worrying. And in dementia, these signs can be expressed as behavioral changes. You may see pacing or restlessness, or an urgent need to stay close to a family member or a familiar caregiver. So we need to take a look at what is going on and what is the person with dementia trying to communicate. And that's how we can diagnose if there's anxiety along with that. And again, normal anxiety, it helps us stay alert. And again, it's part of healthy functioning, but clinical anxiety will interfere with daily life. It's more difficult to control. It worsens over time. It may cause significant distress. So recognizing when anxiety crosses that threshold is critical, especially in older adults who may minimize or even misinterpret their own symptoms. So, why does anxiety increase with age? As we age, people often face more medical appointments, medication changes, losses in their lives, whether it's a loss of independence because your car is taken away, or you're grieving over the loss of family and friends. There's also physical challenges that you experience. And even positive changes like moving from the home you've lived in all your life to whether it's an independent living community or an assisted living community. All of these can feel overwhelming and feel like anxiety. And then if you have dementia, for someone with dementia, even small triggers can escalate anxiety. It can be as simple as rearranging furniture or a loud TV or walking into a room that has a lot of people with a lot of noise. So we need to be aware of all of these things. And especially, cognitive changes can make the world really feel unfamiliar. And with changes in our mobility, there's a fear of falls and accidents. We may have financial strain as we get older. Thought you had enough money to care for yourself, but thankfully you're living 10 years longer. So we need to pay attention again to the aging adult as anxiety will increase. So anxiety disorders are not all the same. The list here are the most common types: generalized anxiety disorder, social anxiety, panic disorder. For example, a panic disorder may look like sudden distress, while PTSD may present as heightened startle response or even avoidance. People may experience agoraphobia. And then when you talk about specific phobias, a phobia is an intense fear or aversion to specific objects or situations. Though it might be normal for someone to be anxious about something, with a phobia, the fear or anxiety that one feels when presented with the situation or object is disproportional to the actual danger that would potentially be caused by the situation or object. An example of these phobias are a fear of flying or a fear of heights or spiders. Other anxiety disorders are OCD, obsessive compulsive disorder, and as well as PTSD. And each disorder has unique features, but they all share the underlying patterns of fear and worry and behavioral avoidance. So let's take a look at emotional symptoms. Emotional anxiety can look like persistent worry or dread. It can look like tension or irritability or hypervigilance. A person may constantly anticipate danger or, what is the worst case scenario? And these emotional signs are especially important to notice in older adults as well as people with dementia who may struggle to verbalize fear directly. So you may see emotional symptoms show up again as irritability or fearfulness or agitation or shouting or even hitting or pinching, things like that. And or they might be saying statements like, what's happening? Where am I? Or I want to go home, because they're looking for something that's safe. So these are some of the emotional symptoms that you may see. So, what are some of the physical effects of anxiety? Because anxiety isn't just emotional, it affects the entire body. So, symptoms may include a rapid heart rate, sweating, shortness of breath, um, trembling. You might have nausea or a stomach ache. There could be disruptions in sleep. You may see muscle tension and fatigue. Um, and in older adults, these symptoms may be mistaken for medical issues, and it can lead to unnecessary tests or even significant emergency visits. So, understanding the mind-body connection here of anxiety is so important. So, what are the effects of anxiety on the brain? Chronic anxiety alters brain functioning. It activates the amygdala, it increases cortisol, and it disrupts neurotransmitters like norepinephrine. And over time, elevated stress hormones can affect memory and concentration, and especially in people already living with a cognitive impairment. So, over time, cortisol affects the hippocampus, and that's the part of the brain that's responsible for memory. This is why anxiety can worsen forgetfulness and confusion, especially in a person living with dementia. So, this overlap is one reason that anxiety can accelerate the progression of dementia symptoms because of the cortisol and the release of norepinephrine and stimulating the amygdala and the hippocampus. So, what are some other contributing factors? Many factors increase risk, anxiety risk in older adults. Medical conditions. There are significantly more issues like heart disease, thyroid disorders, COPD, cancer. There's chronic pain, from your joints, from your bones, from your muscles. There can be medication side effects because people over 65, can have more than five or more medications that they're taking on a daily basis. So there are a variety of side effects from different medications. There can be alcohol or drug use or withdrawal. There could be a past trauma that they've experienced. They could be experiencing social isolation because of their anxiety, or loneliness from loss or from dementia itself. So, you also have to take a look at it. Just do they have a family history of anxiety disorders? So identifying these underlying contributors is so important so we can address the root cause rather than only the behavior. So behaviorally, anxiety may present as avoidance, as restlessness, pacing, recurring or unexpected panic attacks. People may stay away from crowds. They may avoid specific objects or even places, and they might fear being separated from either their caregivers or their family members. Um, People may stay away from crowds because of their fears. And in dementia, the behavioral indicators like shadowing or repetitive questions often signal anxiety rather than acting out. And it's so important always to remember when you see these behaviors with a person living with dementia, it's always a sign of communication. It could be pain, it could be anxiety, and it could be depression, as we'll discuss in a little while. So, health-related anxiety. Anxiety commonly coexists with serious medical conditions. For example, many individuals experience anxiety, after a panic attack. If someone has Parkinson's disease, they may experience anxiety as well. When facing chronic respiratory issues or cancer, fear of falls, there may be elder mistreatment, social isolation. Also, all these things heighten anxiety in older adults. And awareness of all of these connections helps really guide a more holistic intervention. So we need to look out for the underlying health-related issues like the heart disease, COPD, endocrine disorders, depression, fear of falls, and again, loneliness and isolation. It's important to understand that anxiety can be a side effect of medications or, again, underlying medical issues. There could be thyroid problems as well. It often does coexist with depression, so it worsens sleep and cognitive symptoms. So we definitely need to screen for reversible causes, and this should always be part of a care plan. So it's important for the healthcare professional to complete a thorough assessment to rule out any medical problems like thyroid or adrenal issues that can have similar symptoms like anxiety. And we need to be aware of all the medications so we can take a look at what the side effects of the medications could be. And then the caregivers and healthcare professionals need to be aware of these side effects of the medications as well. And anyone taking medications for anxiety should always be under the care of a physician. So, how do we treat anxiety? There's many different ways to treat anxiety. The two most effective treatments are both pharmacological and non-pharmacological, medication-based and non-medication-based. Non-pharmacological approaches are what we hope to be the front line. Counseling, there's cognitive behavioral therapy, stress management, relaxation techniques, structured routine, support groups are highly effective. Music therapy, again, a structured activity, consistent caregivers. Environmental adjustments are also important. Medication can be helpful, but they have to be used cautiously due to the side effects. It could create a fall risk or confusion. Medications, again, may help, but they may not cure the anxiety. Important to use caution with older adults, especially those with dementia, due to the sensitivity of side effects. Let's take a look at this video on breaking the anxiety cycle.
Let's talk about the anxiety cycle in 2 minutes. When we interpret a situation as potentially dangerous and then we avoid it, our brain sends out this rush of relief, as if to say, "Whew, that was close, I could have died." But our brain doesn't stop there. It then says, "Let's make my human do that again so I can survive the next time." So it then increases our anxiety around a situation. Avoidance of things that we think may be dangerous is the one thing that actually makes our anxiety grow and grow. But avoidance can be addictive because it feels good in the moment. Anxiety is a natural and helpful emotion that is supposed to protect us from real physical danger, like rattlesnakes and cliffs. But when we feel anxious about things that are actually safe, like public speaking or social situations, and then we avoid those situations, we can actually create a heightened anxiety response that leads to more and more avoidance, which leads to more and more anxiety, which spirals into a situation where our world is shrinking as we avoid more and more situations. This is called the anxiety cycle, and it not only gives us a clear explanation of what causes our anxiety to increase, but it also shows us the key to decreasing anxiety. So just as the brain learns something is dangerous when we avoid it, it can also learn that something is actually safe when we face it and survive. Our brain's inherent ability to rewire itself is called neuroplasticity. This basically means we can change the physical structure of our brain by changing how we think and how we act. In essence, the most powerful and effective way to combat anxiety is to distinguish between real and perceived danger, and then to gradually face those fears instead of avoiding them. When we do this, our brain learns that we're safe and decreases our anxiety. Now, obviously, this sounds easy, but in practice is quite hard, and therapists have broken this process down into bite-sized chunks. So check out my more in-depth videos if you'd like to learn more.
So now let's take a look at dementia and anxiety. In dementia, reduced neurotransmitters like serotonin and dopamine and norepinephrine create a brain that's less able to regulate fear. So this leads to anxiety and agitation and irritability. Environmental factors like noise and clutter and unfamiliar surroundings can then intensify anxiety. So our goal then is to create a more supportive environment, consistent routines that will reduce stress. Let's take a look at this video on the effects of stress and anxiety on the brain. Important to remember that stress and anxiety can happen to anyone, but they are prior important things to be aware of that can increase your risk of dementia, as well as have these things while having dementia, which again is what we're talking about. So let's see how we talk to and respond to a person who is having a panic attack. When someone is experiencing a panic attack, it's important for us to stay calm. So really check yourself first. Don't raise your voice. Don't show alarm. Don't restrain. Don't criticize. It's important that you don't ignore them. You don't argue with them either. Use slow and reassuring communication. You absolutely do not want to argue or correct their interpretation of the situation. You want to keep your own movements controlled. You want to be able to offer support, use words of reassurance, show compassion. You want to be able to create a quieter and safer environment. It's your calm presence that will help regulate their fear response. Your calmness will become the person's anchor. So you you speaking slowly, keeping your tone gentle, avoid overwhelming them with too many words. That increases the stress and anxiety. Stay at their eye level, maintain a non-threatening posture. So you have to remember your verbal and paraverbal approach. The goal is not to talk them out of it, but to offer safety and predictability. So things to say and not to say to someone who's having a panic attack. Don't say just relax. Whether it's a panic attack or not, have you ever been in a situation where you're anxious and someone says just relax, and think about what does that do to you? It increases your anxiety. It increases your fear. So better to say things like, is there anything I can do to help you right now? And don't immediately say everything's going to be just fine. Be reassuring with whatever happens, we'll figure out a way to make it right. Certainly don't say it's just all in your head. Better to say, would you like to talk about what's upsetting you and work through this? And having you say, I know how you're feeling when you probably don't, you're better off saying things like, I'd like to better understand how you feel. I respect your feelings. Is there anything I can do to help you feel better? And when you're working with a person with dementia, you can say, I can see you're upset. I can see you're scared. I can see that you're nervous. It's okay. I'm here with you. And if you can put your hand on theirs and make them feel better and calm them down, that would help. Don't offer alcohol or drugs. You can say, would you like to get something to eat? Or would you like to be alone? Do you want me to stay? What makes you comfortable? That's what is important at this point. Be able to understand what they're saying and say, I know this is hard for you, and I'll stay with you until you're feeling better. So remember the reassuring words and not telling them to just relax. And strategies for a person living with dementia and anxiety, support begins with really understanding the person's history and their known triggers. This is where person-centered care and personhood comes in. Get to know the person. Who are they? What are their triggers, both internal and external triggers? Is it the environment that there's too much noise or too much light? Talk to their family members, find out, do they have a history of any type of an anxiety disorder? If so, were they treated and how were they treated? And to ask them, were there known triggers? What would set them off? Again, is it loud music? Is it a change of scenery? Is it a new person coming into a room? We need to look at the environmental factors. Is there loud noise? Is there the lights in the room are too bright? Just as we did before, avoid saying calm down. Instead, offer reassurance and stay present. If you can, redirect them and redirect them gently if possible. Prioritize validating the person's emotional experience. Again, don't tell them to calm down. So it's important to establish routines, use consistent caregivers when possible, simplify the environment. If a person is becoming anxious, validate their emotion and offer that reassurance. You're safe. I'm here. Let's do this together. Now let's move into what is depression. Depression it's a medical illness. It's a major depressive disorder. And again, frequently referred to as depression. It's more than just feeling sad or going through a difficult patch. It affects your mood, your thinking, your functioning. It is not a normal part of aging. Again, it is not a normal part of aging. It is a serious medical condition, and it does require understanding as well as medical care. It can affect anyone, all ages, all races, ethnicities, socioeconomic background. There are no barriers to who can eh, be affected by depression. But again, it is not a normal part of aging. But left untreated, depression can really cause major life disruptions and as well increase the risk of suicide. So it's very important to recognize the signs early, and when you do that, that can significantly improve outcomes. Depression is often overlooked in older adults because symptoms can mimic medical conditions or even dementia. There can be stigmas associated with depression. There's generational beliefs, misunderstanding of grief. These all contribute to the underdiagnosis of dementia. I mean, of depression, I'm sorry. In older adults, depression often develops after major life events or chronic health changes. Missed depression diagnosis really increases the risk of a cognitive decline, potential for self-harm, and it's important to know that awareness is the key. Um, People come from different backgrounds and customs. You know, they were taught don't share their personal problems or air their dirty laundry. There can be financial concerns, a cost of treatment. So again, it's very, very important to identify this and treat as soon as possible. Depression affects different brain regions that are involved in decision making and mood regulation, as well as memory. So let's take a look at this a little bit more in depth with this video.
Depression is a complex disease, one that can be triggered by several factors, including chemical imbalances in the brain, medical conditions, traumatic life events, and genetics. But depression can start to lift within just a few weeks, provided you find the right combination of effective treatments. This is Your Brain On, where we explore how the world affects our brains and ourselves. Brain imaging studies show that depression is connected to changes in several parts of the brain, especially in three core areas. The first is the amygdala, which regulates emotions like anger, pleasure, and fear. When a person is depressed, the amygdala can become overactive, causing problems with sleep and behavior, as well as balance of key mood hormones. The second area is the hippocampus, which processes memory and regulates stress hormones such as cortisol. One study found it's up to 13% smaller in depressed women, and excess cortisol can stunt the growth of new neurons, creating poor moods and memory. The third main area is the thalamus, which helps link sensory information to good and bad feelings. Problems in the thalamus may be linked to conditions such as bipolar disorder. Changes to these parts of the brain and others mess with key hormones, such as serotonin, which regulates sleep and mood, and norepinephrine, which affects motivation. For some, a depressed mood passes on its own, especially if it was triggered by a particular sad event. But for those with ongoing clinical depression, it can take time to find effective treatment. Stats show sticking with treatment is worth it. One study by the National Institutes of Health showed 80% of people improved within just 4 to 6 weeks of starting medication, therapy, or support groups. Healthy lifestyle choices can help too. Eating a good diet and getting enough sleep can strengthen and repair important brain connections. Overcoming depression may become easier in the future. Scientists are learning more about how factors such as genetics influence depression, which may not only help create new drugs, but also make targeted treatment possible, helping someone with depression feel like herself again.
So let's take a look at some of the symptoms of depression. Depression changes how people think, how they behave, and how they function every day. All of us at one time or another have experienced one or several of these symptoms. Sometimes they're related to a death of someone close or stress at work or an injury. The difference between those feelings and a major depressive disorder is that you don't have those for more than 2 weeks. And or you have the coping skills to identify and then use those tools. So you need to take a look at, is there persistent sadness or irritability? Is there a loss of interest in activities? Is there an appetite change or are there weight changes? Are you getting too much sleep, too little sleep? Are you extremely fatigued? Do you have difficulty in making decisions? Do you have feelings of worthlessness or guilt or possibly suicidal ideation? And depression in older adults appears a bit differently. So sometimes instead of sadness, they may show fatigue and irritability. There might be memory problems or social withdrawal and, vague complaints of pain. They might have delusions or hallucinations, and they also may have a grief or a loss that they haven't dealt with. You need to look for persistent and vague complaints. There might be vague physical complaints, slowed movements or confusion, behavioral clues like withdrawal or repeated help seeking or demanding behavior, which all indicate distress. Chronic illnesses like cancer, diabetes, stroke, Parkinson's, they all increase depression risk as well. Pain, fatigue, medication burden, functional changes as we age, these all contribute. And recognizing this connection really supports a more comprehensive approach to care. So we need to remember that, again, depression also is not a normal part of aging. Can't stress that enough. Depression is not a normal part of aging, because if we assume it is, then we miss the opportunities for treatment that could really improve someone's quality of life. There are screening tools like the Geriatric Depression Scale that are used regularly with patients who have chronic illnesses, because, like the others, early detection makes such a difference. Certain medications can contribute and trigger symptoms of depression, like sadness and despair and discouragement. And these medications can alter brain chemicals and can lead to feelings of mania or depression. Examples of these are corticosteroids, anticonvulsants, opioids, hormonal contraceptives. It's so important to consult with a healthcare professional if you notice any symptoms of depression after starting a new medication. They can help then determine, is it the medication or is there another factor in contributing to your symptoms? You might be on chemotherapy or antibiotics, even some blood pressure medications can all affect and have a side effect of depression. Medications that treat Parkinson's disease can also contribute to depression. There was a study that said that levodopa, which is used for Parkinson's disease, can worsen depression symptoms, especially when taken at high dosage. Stimulants, although it may sound a bit strange, starting an antidepressant can initially make depression symptoms feel worse. And this can feel discouraging, but we need to assure the people who are on it that it is normal. And for most people, it is temporary. The bottom line here is that there are a variety of medications that can cause depression as a side effect. And we need to know that, many of the health conditions that these medications treat, do cause depression. So if someone has experienced depression symptoms or a worsening mental health, then they need to talk to their healthcare professional, their physician, to determine what is then the best path forward. Depression is more than just feeling sad. It changes how a person thinks, how they behave, how they function every day. It's persistent sadness, irritability, or anxiety. These are often the first signs that we notice. And in older adults, irritability can sometimes replace the classic sadness that we expect with depression. You see a loss of interest in activities that they once enjoyed, and that can include intimacy as well. Loss of interest in hobbies. That's very much a hallmark symptom. Families often will say they just don't seem to enjoy anything anymore. There are sleep disturbances. These are very common. Some people can sleep all the time, and some people can't sleep at all. We will see appetite changes. And again, that goes both ways, whether it's overeating or not eating at all. And you see unintended weight gain or loss. There's cognitive symptoms, which include trouble concentrating, difficulty in remembering things, difficulty in making decisions. There's a lot of indecisiveness. And these can all mimic dementia. So screening, again, is so important. You'll see the emotional toll. They'll have feelings of emptiness or guilt, hopelessness, worthlessness, and then that leads to the social withdrawal and reduced functioning. Depression in older adults often does mimic dementia. So that's why it's important to always assess mood, sleep, and appetite as part of the evaluation. Depression, too, doesn't just affect the mind, it shows up in the body. Patients will report fatigue and decreased energy, describing themselves as being listless or just unable to really get going. They may notice a change in movement. It can be either slowed physical activity or increased agitation and restlessness. Physical complaints are very common. They can have headaches or cramps, stomach issues, digestive issues, with really no clear medical explanation. And then these are often under-recognized as depression. Behaviorally, we see the social withdrawal, reducing in their daily functioning, and sometimes it looks like they're giving up when really they're overwhelmed by depression. Most importantly, depression can lead to thoughts of death or suicide attempts. This is always a red flag, and if present, immediate intervention and referral are absolutely required. So don't assume someone with dementia or a chronic illness is ever safe from suicidal ideation. They're often at a higher risk. Depression is a whole body illness. It's mental, behavioral, and physical symptoms all intertwine. So recognizing these signs early helps us to intervene before the decline becomes potentially dangerous. Depression and dementia have their own challenges. Many older adults grow up in that culture where mental health isn't openly discussed. They can minimize symptoms, avoid treatment out of fear, shame, financial concerns. So it's up to us as clinicians to normalize depression as a medical condition and encourage treatment. That's the mental health problem that we as a society see. And then we see that depression and dementia often coexist. Depression may mimic dementia, sometimes called pseudo-dementia, and conversely, cognitive impairment may mask the depressive symptoms. So always there is a need to evaluate for both conditions, especially, when there's a change in cognition. And because the symptoms overlap, like slow thinking, poor motivation, and memory concerns, that's why misdiagnosis is so common. A person with incorrectly labeled, maybe incorrectly labeled with dementia when they're depressed, or vice versa. And a comprehensive assessment is essential, but you always do have to consider that they are coexisting conditions. So, what are the strategies for a person living with dementia and depression? It's so important to use a person-centered approach and explore their personhood. So learn their history, their past experience. Do they have a history of depression? And if so, was it treated? Listen actively, validate their emotions, look for their symptoms. Are they complaining of vague pain? Are they more needy than usual? Listen, use the positive approach to care. Lean in, listen, paraphrase so they know you're listening. Validate those emotions. Encourage meaningful connection and activities. That social connection is so important. But again, it's important to know who they are and what do they engage in? What brought them joy and happiness in the past and could potentially bring them that joy in the present. Talk with their family, find out what could be making them feel depressed, what's going on in their world. Are there losses? Are there recent moves? So again, it's important to engage the family member, collaborate with mental health professionals, use that validation, active listening. Small successes build engagement and reduce hopelessness. Get counseling, use your chaplain, your priest, your rabbi, talk to a mental health professional, talk to a psychiatrist, talk to a neuropsychiatrist. Always use that person-centered approach. When you are working with someone, be calm, consistent, supportive, validate, identify and acknowledge their expressed emotions. They need to be validated. Whether you have dementia or not, you have that need to be validated. It's important to check in. Daily check-ins really show and demonstrate care as well as stability. Refer to the appropriate professionals when needed. Utilize group activities, peer interaction, engagement with trusted support systems. Remember that depression alters how the brain functions. It changes your brain chemistry and changes your cognition. So be a calm presence. Show that concern because compassionate presence really matters. Treatment can include medication, it can include counseling, lifestyle changes, mind-body approaches like mindfulness, spiritual practices. These all truly help. Medication adherence and social support are so important. Depression is treatable, and improvement significantly enhances someone's quality of life. So let's take a look at some what I call clinical pearls so we can identify dementia versus anxiety versus depression. Some key distinctions. Anxiety often fluctuates and is fear-driven. Depression develops over weeks and is mood-driven. Dementia progresses gradually and primarily affects thinking. Understanding these differences really help us make accurate observation and tailor interventions. So again, the onset is your first clue because dementia is more gradual. Dementia shows progressive memory decline and language decline. There could be depression shows a persistent low mood and withdrawal, and sometimes what we would call pseudo dementia with cognitive issues. But again, when depression is treated, then they can move forward. So it's important to understand these things. And we'll go to another group of clinical pearls. Behavior patterns, they can help differentiate the conditions. Dementia causes repetitive questioning or disorientation. Anxiety leads to avoidance, pacing, or clinginess. Depression causes withdrawal, fatigue, or reduced motivation. You have to ask yourself, is this thinking impaired, which would be dementia? Could this be fear-based, which is anxiety? Is this mood-based, which is depression? So observe responses to reassurance. Anxiety improves, depression may not, and dementia may show little change. And, if you remember some of these pearls, then you'll be able to differentiate more easily between dementia, anxiety, and depression. And then you can then advocate for more appropriate interventions. Let's take a look at our key takeaways today. Dementia, anxiety, depression, they frequently coexist, and the symptoms can look similar. We know that anxiety and dementia can often present itself as agitation, pacing, repetitive questioning, fearfulness. Depression in older adults shows up as withdrawal, slowed thinking, somatic complaints. You always have to consider medical, environmental, psychosocial. These can all be contributors, and you have to assume that before assuming it could be a behavioral diagnosis. There are non-pharmacological strategies, and that's what we try first. Use a routine, commit to reassurance and validation, no arguing. Sensory approaches are important. These are our first line interventions. Medications can help, but we know they require careful monitoring. There is an increase in sensitivity and side effects in older adults. Supportive communication, empathy, and observing, using individual history. That person-centered care approach is so important for reducing distress. Find out who that person is, know their personhood, and what helps them, what brings them joy in life. Early recognition for any of these is important, and to be able to give appropriate treatment leads to better outcomes and improves daily functioning, especially with a person living with dementia. But really, the most important thing here is that early recognition and intervention will improve those outcomes and increase the quality of life, not only for the individuals, but their caregivers as well. I appreciate you joining us today. I thank you. If you have any questions, please take down my email address and feel free to reach out with any questions.